really grateful for the chance to talk with you about vaccine equity and with the other experts on the panel. And I just wanted to really give you a few more things to think about to set the stage for the comments of the other speakers, and share with you a few slides that I think will illustrate some of the points that I want to make. So, but we can just leave this slide up while I take you on a bit of a journey that I went on preparing for this. So maybe many of you were like me, and you kind of have lost a little bit of a sense of time during the pandemic. So when I thought about this presentation, I really had to retrace my steps to think, what were my reactions to the data? What was my reactions to the information that was coming out? And what was my reaction to exactly what John Michael was encouraging us to think about, how people on the margins were really faring through this pandemic. And as CEO of an organization, CMMB, that works on supporting healthcare delivery globally, particularly in lower resource settings, from the beginning, I was really thinking about how is COVID going to play out in the developing world. That's where I spent my career working on programs around the world. But it was really hard to focus on that at the very beginning. So maybe some of you remember, like I do, like after the first stories out of China, there was a lot of grim pictures of the situation in Italy and parts of Europe that were heavily affected in February and March of 2020. So that was my first kind of seeing it come to life on news screens in front of me. And then I live outside New York City, and just seeing the numbers creep up in New York in April and May, seeing ships brought off the coast to handle extra patients, to seeing trucks that were hospitals that were overwhelmed, and trucks that were iced for the casualties. That was really my experience of the epidemic in the very early days. And maybe a lot of you can also kind of remember where your thoughts were and what your initial concerns and reactions were, and who you worried about in your family or in your community. CMMB started working with the Catholic Cares Coalition early this year, but with this particular concern, thinking about global vaccine equity due to our own work in global health. But working with the coalition really reminded me that we also really needed to look at equity in our own neighborhood to start. So from those early days of the pandemic, you may remember the news stories that we had seen in the United States about how various populations, particularly people in minority groups, were suffering greater infection rates and worse outcomes than people who were white. Some of this could have been due to the employment of those persons who were disproportionately working in healthcare or service industries or production industries, where work from home was not an option. I had to recognize my own privilege that was something I could do, was work from my house, but that wasn't an option for everybody. Or maybe for other people, they lived in crowded settings where it was much easier to transmit the virus, or much harder to isolate if you found out you were infected. So I personally knew the first two people I heard of who succumbed to COVID happened to be a Hispanic father whose children went to grade school with my children in the suburbs, and a nurse that I knew who was born in Africa, and she got infected working at a hospital in Queens. So my own experience of COVID from those early days was just, I had this sinking feeling, like in so many other areas of public health, in some way your racial or ethnic background or your zip code was going to determine your infection rate, maybe the severity of your illness, and even the quality of care that you received. And then the research really bore this out. So if you go to the next slide, this is, I just collected some slides that I thought might help you guys have a picture of some of the data that really challenges our reality about whether we were trying to do things equitably. This is relatively old data because the Atlantic discontinued this project in March of 2021, but it does give you a picture of the outcomes that were worse among minority communities than for white communities. So that's not to say that there weren't illnesses or poor outcomes for whites as well, but I personally felt like I was hearing more stories of people of color who were affected. And I, maybe like some of you, finally felt like I had to stop watching the news, as I found it really difficult to watch solitary people often suffering in hospital rooms, exhausted health workers who are putting themselves at risk, like the nurse I knew who lost the battle with COVID in May of 2020. So that's how I was feeling at the beginning of the pandemic. I don't know about many of you, but once I heard the news of vaccines that were in the final stages of development, that came out in sort of the late 2020, I felt a tiny bit of hope after a long, sad spring, summer, and fall. And I hope that, at least to begin with, we would really take care of health workers, that they would have early access to vaccination. Older people who are at high risk and also were suffering from the effects of prolonged isolation, they would get their vaccines early as well. And that we would find ways to protect the communities that seem to be suffering the most consequences. So it does seem that the rollout coverage in the United States did begin with health workers and other direct service providers, older Americans, and increasingly, though that got covered, we weren't maybe successful, and we'll look at some data later about economically vulnerable populations and people of color. That didn't necessarily happen as well in the United States as we would have wanted if we were looking at this work with a health equity lens. So there are many sources of this data. I'm going to share one at the end of the presentation to just look county by county, but I'm sure a lot of you have been watching this data as well. So given the work of my organization and some of the vulnerable and fragile places around the world, I expected that health workers would quickly be vaccinated in other countries as well, as they really are our first line of defense. And then we would go on to other vulnerable populations. But looking at the data and recognizing the investment made by the US government in vaccine development, frankly, the United States was going to benefit from the fruits of this research and the ability to pay top dollar for the successful vaccine candidates. That was going to be easier for wealthier countries. At the same time that people began writing about that topic, in December of 2020, Pope Francis began speaking about the importance of, or the important challenge in front of us in terms of vaccine distribution and equity. And he recognized that there was going to be this global competition for vaccine purchasing, and it was already emerging. The first vaccines were being purchased by the US and the UK, the AstraZeneca vaccine, in May of 2020, before any significant research had even been done on the vaccines. So if you just go to the next slide, the Pope, being concerned about these issues, was speaking at the beginning of the World Bank meetings in a letter to the World Bank and the IMF meetings in April of this year. He said, we cannot allow the law of the marketplace to take precedence over the law of love and the health of all. That was a very important message. It echoed his comments about us all being in the same boat, about themes that were covered in Fratelli Tutti. But unfortunately, by that time, by April of 2021, the writing was already on the wall, as so many governments had pre-ordered vaccines. That is, they were not even assured that the vaccines would work, but they were worth ordering in case they proved effective. And because they weren't sure which vaccines would prove effective, governments with the money invested and hedged their bets by buying and advance purchasing even more vaccines from different manufacturers to make sure that they would lock in some winning options. So what did that look like? I have a couple of graphs I wanted to share. If you can bring those up, Victoria. These were put together by a group called the Duke Global Health Innovation Center. They have a website that's really worth looking at that's called launchandscalefaster.org, and it has a whole section on COVID-19. So if you're interested in this kind of data about the purchasing, about how this all happened, that inequity got baked into the equation very early, and you can see in the data that Duke has collected. So wealthier countries started placing orders, as I said, as early as May of 2020, before any of the vaccines were considered even quite viable. And by the summer of 2020, Canada, the UK, and the EU countries had already purchased more than enough vaccine for their populations, pre-ordered more than enough vaccine for their populations. So this first table shows the income groups of countries that have ordered vaccine purchases to date, showing that wealthier countries were able to put in orders for 9 billion doses of vaccines, if you add up those first two columns. And then low and middle income countries combined purchased only 3.5 billion doses. And COVAX, which is the facility that was set up by UNICEF and Gavi and other international agencies to help procure vaccines for lower income countries. They had ordered 3.2 billion vaccine doses. So it just goes to show that a lot of the market had already been kind of cornered by wealthier countries very early on. The second table, if you switch to that, Veronica, and I'm sorry, I put a little thing about the EU on there. It shows that Canada led the way with purchase orders for 10.4 vaccines per inhabitant in Canada. The EU is at 7.07. In the United States, the US government pre-ordered 5.2 vaccine doses per person in the United States. So it just shows that, again, there was this mass rush, just what the Pope had warned us about, of letting market forces kind of control the way that the vaccines would be distributed. But there were massive purchases by countries that were high income countries, and then some middle income and lower middle income countries found that they were a little bit behind the eight ball and got into the game. So you see, Brazil, Peru, et cetera, trying to get involved in advance ordering vaccines. All of these things get back to this issue of health equity and what we wanted to talk about today. What do we even mean by equity when it comes to healthcare? Fortunately, we have an ethicist on the panel who can probably better explain the topic and some of the relationship to our own Catholic social teaching, but let me share some perspective from a public health professional. Basically, equity has to do with whether some groups are systematically kind of left out or structurally denied care because of a certain characteristic. And if you go to the next slide in trying to research the topic, I found this definition quite helpful. So health equity from Paula Braverman at UC San Francisco. Health equity means social justice in health. That is, no one is denied the possibility to be healthy for belonging to a group that has been historically economically or socially disadvantaged. I found that definition very helpful, and it really is something that is how we have been paying attention to vaccine equity as part of the Catholic Carers Coalition. Are there groups that are systematically left behind or being denied access to the vaccine because of their economic or social status? So we have to look at whether the system that was, I don't even know if we can say it was designed, but the system that happened in terms of vaccine buying and vaccine distribution around the world was designed to create equity, or whether structural barriers continued to exist, which gave some priority and others were left without protection. If we look at that just in the United States, going back to the US context, where at least initially just applying for appointments, I mean, maybe some of you remember I was trying to help older folks in my parish get appointments online because they couldn't manage the New York State website. So people trying to use technology left many people without access to the vaccine who wanted to get vaccinated, but they either were not computer literate or they didn't have access to Wi-Fi. And that really is the case for many socially disadvantaged groups. There were also uneven education about the vaccines themselves, concerns among some groups about, including valid worries about past medical testing, and some circulating misinformation that reduced getting vaccinated early. So there were people who wanted to get vaccinated, but found barriers. There were people who had doubts and they hung back and didn't elect to go get vaccinated early. And then if you look at, there are also studies of things like what's called greater vulnerability. So the CDC has a measure of socioeconomic status, housing, transportation, ethnicity, and race. And that does show lower vaccine coverage rates in more vulnerable, less affluent communities around the country. So while Margaret is right, in the last week or so, the last couple of weeks, the spread of the Delta variant and today's good news on the FDA approval of at least the Pfizer vaccine, we're hoping that more people who've been previously hesitant will go and get vaccinated. But to date, we have very uneven coverage in the United States. So maybe if you bring up the next slide, we'll show this is the COVID vaccine tracker map. that I think I pulled this from the New York Times website. I know a number of people are featuring this data, but it's a county by county tracker. And you can see there are certain counties in certain states. You can, when you hover over a specific county, you can find out how that county is doing. But there are certain places in the United States which definitely had better coverage, maybe because they had more educated people or there was a greater outreach, et cetera. But there are other places in the United States, particularly where we've seen the Delta variant quite causing a lot of hospitalizations in the southern United States, where there wasn't as much coverage with the vaccine. And so this very uneven map of coverage suggests a lot of things that are going on behind the scenes that have led to inequitable distribution of the vaccine in the United States. If we wanted to look at then what's happening on the international front, as I said, the buying power of more wealthy countries affected early access to the vaccine. And then there's a second problem, which is even once COVAX was able to purchase the vaccine and started to deliver the vaccine to countries, there are a lot of complicated mechanisms needed to deliver the vaccine to actual people. Getting shots in people's arms was also complicated. So there was a slow release of funds to COVAX from donors that hampered their ability to enter contracts. And then there were complicated mechanisms for those contracts. And then there's a difficult situation on the ground. COVAX needed to find both the money to buy vaccines, but also help governments be ready to distribute the vaccines on the ground. And that required refrigeration for a number of the vaccines. Most of the vaccine candidates required very cold refrigeration. It also required transportation. It required mobilization of communities on the ground to get in place to come to the vaccination center. And they had to have skilled staff ready to go. And CMMB has been part of vaccination mobilization in Haiti. We've also been part of vaccine distribution, bringing it out to communities in very rural South Sudan. That we had to have skilled staff ready to go. We had to have the cold chain maintained so that the vaccine could be kept cold. And we had to do this on a very fast turnaround amount of time. So it is a complicated vaccination program to run. And most countries don't have experience running vaccination programs for adults. It's primarily the vaccination programs that most of us in public health are familiar with are really established to vaccinate small children. So if we look at the next slide, that tells you a little bit about the results of this kind of uneven coverage. So this is also from the New York Times, which has great coverage. If you don't subscribe to the New York Times COVID page, you really might want to. It shows how many daily doses per 100,000 people have been given out since the vaccines became available. So you can just see in this diagram how far behind Africa really lags. And you have to ask yourself whether there's any ability to catch up. What would the goal was to have Africa vaccinated at about 20% by the end of the year. And that to me looks like a very difficult goal to achieve by the end of the year, given the current status. So, we are part of one big human family. We have, 211 million cases confirmed globally. That's likely an underestimate because many people were undiagnosed around the world. There have been 4.4 million deaths globally. That's also possibly an underestimate. And 4.9 billion doses of the vaccine administered. And you can see from the slide just how inequitably that distribution has taken place around the world. So it feels to me like we're in a very difficult spot to even talk about getting closer to vaccine equity because there's so much work that has to be done to redistribute vaccines to both the resources that are needed to get the vaccines, but also the resources that are needed to deliver them on the ground. And that is really going to be the big challenge for vaccine equity as a global concern. Just one final concern that I have is just this weekend, the United States government began to okay booster shots for eligible Americans. So first, there was a discussion just about those with weakened immune systems. Now they're really talking about the need for getting most Americans a booster dose. later this year, sort of 6 to 8 months after you completed your vaccine. And I just, wanted to quote one WHO official who really likened it to giving people with a life jacket an additional life preserver rather than passing them out to people who still don't have a life jacket. So that's, to me, some of the really important global health equity concerns that I'm really feeling as I look at these issues and as I participate as part of the Catholic Cares Coalition working on vaccine equity. So I hope I've given you a few things to think about and some data that is worth considering as we consider health equity. Thanks.
Thanks, Mary Beth. I put a poll up actually to have people think about, have they considered the ethical issues around receiving the vaccine while others have no access, just so we can kind of get an assessment of where people are. I think you've done a great job in helping us begin to form a deeper sense of awareness and conscience formation. So thank you for that. But I also wanted to pull out something from the chat that you actually, it was put in the chat prior to one of your last slides, that really wanted to have us keep in mind that procurement is one thing, effective distribution without any delays is another thing. And yet there is this third challenge of effective, equitable in-country vaccination. And one of your opening comments was how early on you wanted to turn off the news. And I think that really resonated with most people in this room together. What advice do you have for folks when it's just become so overwhelming and we feel somewhat defeated, especially at this stage of the pandemic, around these issues of equity? What is your advice of one thing that someone ordinary like myself could do to really make a difference?
I mean, I think, we've been involved in advocacy, really trying to talk to the Biden administration and other people in power about the importance of sort of sharing the surplus, about sharing the resources to create vaccines elsewhere, not just in the United States and not just in Europe, but the importance of sharing the technology so that vaccines could be developed, delivered, produced in more places so that we could get the numbers bigger. But the comment in the chat is right from my colleague Ariel, like even if we had the numbers, we have to also have the systems on the ground ready to distribute safely. So using your voice to talk, if you feel like you can talk to policymakers, talk to policymakers. If you feel like you can't talk to policymakers, you really can talk to your neighbor. I mean, I have a son who has a number of friends who are in their 20s in the United States who have not been vaccinated yet. And I've just been really trying to lean on him. Like, this is important. This is something you can do. They could be interacting with children who are too young to be vaccinated. They could be interacting with older people who have immune compromised positions. Like they have a responsibility to take care of their neighbors. And I really, I immediately ordered my CHA USA mask that said, "Love thy neighbor." It's really something I wear all the time. I just spent a week in the Midwest wearing that because people aren't asking, they are not thinking about the implications of my actions have on my neighbors. And so I just think even if you can convince one person, I would consider that a real victory. A person is resistant, trying to give them the information that might help them really consider the impact on themselves and people around them.